Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on today's video. On today's video, we're in part 2 of our new series entitled Orthopedic Essentials for the Qualified Medical Evaluator. And in this series, we're talking about important concepts related to chapters 15, 16, and 17 of the AMA guides, and specifically related to true positive objective findings in the physical examination of the spine, of the upper extremities, and also of the lower extremities. And the philosophy that recurs throughout this program is that the AMA guides are largely dependent upon what they refer to as objective examination findings in the determination of permanent impairments and in the assignment of accurate permanent impairment ratings. Well, it's interesting because in the face-to-face evaluation with injured workers in the workers' compensation system here in the state of California, injured workers bring to us loads and loads of subjectivity. And throughout the morass of all the subjectivity that examinees bring with them to the examination room, it's our obligation as qualified medical evaluators to sift through the subjectivity to arrive at what's truly objective in relation to the examinee's condition. So it's important to understand the nature of true objective findings in the physical examination and in the assessment of the examinee's statement of limitations to activities of daily living. And we'll talk more about activities of daily living and limitations with activities of daily living in today's discussion. So before we begin today's session, which is part 2, I just want to review a couple of key principles that we reviewed in part 1 of this series. And that has to do with several important concepts related to pain. Now, it's no surprise to you, if you have any number of qualified medical evaluations under your belt, that examinees in the face-to-face evaluation report pain to the qualified medical evaluator. So you're going to be hearing lots and lots of subjectivity related to pain. Well, one of the important concepts related to pain that we discussed in session 1 of this series is based on the definition itself of pain. So pain is defined by Merriam-Webster as an unpleasant sensory and emotional experience, often related to actual or potential tissue damage, and typically leading to evasive action. And it's this latter component of the definition of pain that is typically leading to evasive action, which is a key principle that we can rely on in assessing our examinee's true condition. True pain leads to evasive action. And many of the physical examination maneuvers that we're going to employ in the physical examination will provoke pain. And in the presence of bona fide pain, the examinee should demonstrate a true positive objective finding, which is some form of evasive action away from the pain. It's quite interesting. So in the definition of pain, wherein Merriam-Webster refers to as evasive action away from pain, this is well known to us as doctors. And this is something that we learned in our neurophysiology courses, probably even in our undergraduate training, where we learned that evasive action is nothing more than a manifestation of the flexor withdrawal response. Remember, with the flexor withdrawal response, we learned that when you touch your finger to a hot stove, or when you step your big toe on a tack, or there were many examples and demonstrations of the flexor withdrawal response. But just imagine touching your finger to a hot stove. When you touch your finger to a hot stove, there is a reflexive, evasive action away from the hot stove. And the reflexive action involves co-contraction of multiple muscles in the upper extremity that cause flexion at the shoulder and elbow to remove the finger from the injurious stimulus, which is the hot stove. So the flexor withdrawal response is an evasive action away from pain. It's reflexive. It's not cognitive. So it takes place with a certain speed, with a certain rapidity, and with a certain quantity of flexion of the involved articulations. It's quite characteristic in the presence of bona fide and actual pain. So an examinee who's undergoing physical examination maneuvers, when those physical examination maneuvers provoke the examinee's pain, the pain should be accompanied by a true positive objective finding of evasive action away from the pain. Now, you're familiar with this phenomenon because many of the physical examination maneuvers that you've learned over the years typically involve evasive action. So if you think about, for example, the shoulder apprehension maneuver that we employ in the assessment of shoulder instability syndromes, the shoulder apprehension maneuver, if you remember it described in many textbooks, shows the examinee going through this particular range of motion that leads to or provokes or causes an instability or dislocation in the shoulder. The examinee will get a look of apprehension on their face, kind of like that, which is how they depict it in the textbooks. But then typically also the examinee will produce an evasive action to reduce the amount of pending instability or to reduce the potential for a pending dislocation. And it's that reflexive action, that evasive action away from the pain, that constitutes the true positive objective finding. So as we go through our physical examination maneuvers, and as we assess our examinees for pain behavior, and as we assess our examinees' statements regarding their limitations to activities of daily living, we're always going to be looking for the telltale and true positive objective finding, which is the evasive action away from pain. So that was one principle that we talked about in session 1 of this series. The second principle that I just want to review with you has to do with largening and diminishing lesions. So it's interesting, when a lesion is worsening or enlarging or going from bad to worse, it's typical for the examinee to describe the pain pattern and pain distribution as enlarging. So this is referred to as peripheralization of symptoms. And in our last discussion, we used the example of a herniated lumbar disc getting bad enough and large enough to involve the localized spinal nerve root, let's say for example L4 nerve root, L5 nerve root, S1 nerve root. As that lesion enlarges, the distribution of pain peripheralizes from the site of the lesion, which is at the L4 or L5 level of the spine, and will produce symptoms even distant from the site of lesion. So this is known as peripheralization of symptoms. Now, conversely, when lesions diminish, when lesions improve, as lesions heal, then we see the opposite phenomenon, which is known as centralization of symptoms. So in the case of an L5 nerve root radiculopathy, causing pain all the way down into the foot, as that lesion improves, the symptoms will recede and resolve from the foot on up back into the source of the lesion. So the examinee will tell you that the pain is no longer in the foot, but it's still in the calf. And then after it resolves from the calf, the examinee will tell you that they still have pain, for example, in the thigh. Well, as the lesion continues to improve from there, the symptoms recede, and eventually become localized to the site of the lesion at L4 or L5 vertebra, and we refer to this as centralization of symptoms. So by the time we see examinees in the workers' compensation system, much time has passed, much treatment has been provided. The examinee may have been removed from the injurious environment and is now either on work restrictions or even possibly on total temporary disability. So with time and treatment and the healing benefit and the healing tincture of time and treatment, we should see centralization of symptoms. If the examinee continues to report peripheralization of symptoms, that would be a red flag that would require further investigation. Okay? So a couple main principles to help us guide our history taking and our physical examination in the face-to-face evaluation. Now in today's discussion, I want to continue on pain concepts for the qualified medical evaluator, and we're going to talk about the various types of pain that can originate from different types of tissue within the body. And then I want to go into a discussion about the various levels of pain. Now, if you've been a qualified medical evaluator for any length of time, you're probably familiar with the 1997 Permanent Disability Rating Schedule, where we used to employ what were referred to as words of art in describing the examinee's subjective factors of disability. So we used to talk about minimal pain. We used to talk about slight pain. We talked about moderate pain, and then there was severe pain. Well, we're going to resurrect these pain concepts because they still have validity even in those cases that employ the AMA guides versus the 1997 Permanent Disability Rating Schedule, because these concepts of slight, minimal, moderate, and severe pain carry with them characteristic pain behaviors. And we'll talk about those. In addition to those 4 levels of pain, I want to talk to you about 7 levels of pain that are associated with repetitive stress and or cumulative trauma injuries. So this will give you great insight into those cases where the examinees are reporting cumulative trauma, repetitive stress type of injuries. Okay, so with no further ado, let's begin today's discussion in investigating pain concepts for the qualified medical evaluator. Okay, now with the types of examinees that we're going to be generally seeing that we assess in chapters 15, 16, and 17 of the AMA guides, we're typically going to be seeing neuromusculoskeletal types of injuries involving injuries to the muscle tissues, connective tissues, neural tissues, bone, and vascular tissues. So these types of tissues are associated with characteristic descriptions of pain. So for example, examinees who are suffering from muscular and musculotendinous types of injuries, they will describe their pain very characteristically. Typically and commonly, they'll use words such as cramping pain, dull pain, and aching pain. And it's interesting because muscle is the only tissue capable of cramping and going into hypertonicity and even spasm. So examinees, even though they're lay people, use the type of language that describes what it is they're feeling based upon an abnormal function of the muscle. So they'll use words such as cramping and tightening types of descriptors in describing their pain. Now with injuries to ligament and joint capsule structures, examinees will describe a dull and an aching pain. And this is pain that is coming from deeper structures rather than from the more superficial structures such as muscles. So the pain is more difficult to localize, and it feels more of a dull and a poorly localized aching type of pain. So in Spanish, one of the words used to describe aching is dolorido or dolorcito. So you'll hear examinees use this type of word, which is translated as an aching pain in English. Now with a nerve root pain, if you've ever suffered a nerve root injury yourself, such as a burner or a stinger, you'll know that that's a sharp and a shooting type of pain, and the pain shoots along the distribution of the spinal nerve root. So many people will describe this as an electrical pain, as a lightning pain, as a bright zapping type of pain. And when you get these descriptions, you know that you're dealing with a nerve structure, typically a nerve root pain. Now, peripheral nerves, because they go out into further parts of the body, and because they contain different types of nerve fibers. Remember, a peripheral nerve carries mixed nerve fibers, both afferent and efferent fibers. Examinees will describe this as a sharp, bright, or lightning-like pain. And if you've ever hit your funny bone nerve, your ulnar nerve at your elbow, you'll know that you get a lightning-like zipper, electrical shooting type of pain down the distribution of that ulnar nerve into the ring and pinky fingers. So it pays to remember how this feels on yourself when you strike a superficial peripheral nerve yourself. Also commonly involved peripheral nerve involves the common peroneal nerve as it courses around the head of the fibula in the lower extremity. If you yourself have ever struck that nerve, maybe on a bench or a bleacher seat, you'll know and you'll agree that that's a sharp, bright, lightning-like electrical shooting type of pain that goes immediately down the distribution of that peripheral nerve. Now, peripheral nerves, as I said, are mixed nerves. They carry somatic afferent and somatic efferent fibers. They also carry autonomic afferent and autonomic efferent fibers. And in the case of involvement of the sympathetic nerve fibers, such as in chronic regional pain syndrome or causalgia or reflex sympathetic dystrophy, whatever term you prefer to use, examinees will describe this as a burning, pressure-like, stinging, and aching pain. And in Chapter 17 of the AMA Guides, in the section dealing with chronic regional pain syndrome, the AMA Guides use the word burning in describing this type of pain. So examinees who have suffered an injury to a peripheral nerve, either through trauma or through a surgical lesion that involves the sympathetic nerve fibers, they will describe this as a constant and severe burning type of pain. In some cases, it's so severe that it interferes with all or most activities of daily living. Now, more rarely will we see involvement of bone and vascular pain, but with bone lesions and pathologies to the endosteum and pathologies to the bone marrow, the examinees will describe a deep, nagging, and a dull pain. And again, this is a poorly localized pain because it's coming from deeper structures that are innervated differently from the superficial structures that have many specialized sensory receptors, such as in the skin that has many specialized sensory receptors. Well, the deeper structures have fewer and less specialized sensory receptors, and so the pain is poorly localized. It's difficult to define, so they will use terms like deep, nagging, dull, aching, boring type of pain, and this is an indication that the lesion is coming from a deeper bone structure. Now, in the case of a fracture, a recent fracture, and we rarely see these cases in the workers' compensation setting because our examinees come to us months and years after the initial date of injury. But just for your edification, when you have an examinee who describes severe or sharp, intolerable pain, this could reflect injury resulting in a fracture of the bone. And this type of pain is typically referred from the periosteum. The periosteum, you'll recall, is richly innervated with nociceptive endings, and when the periosteum is disrupted, and the periosteum and those sensory receptors are stimulated, it leads to a sharp and a severe intolerable type of pain. And this is the basis for our periosteal testing using our tuning fork in the physical examination for the assessment of a periosteal reaction related to fractures. So we rarely will see these types of pain descriptions in our face-to-face evaluations because our examinees are presenting to us in the chronic rather than the acute condition. So if you have an examinee who complains in the chronic condition of sharp, severe, intolerable pain, that would be a red flag that would require further investigation or further inquiry. Okay? And then finally, pain related to dysfunction of the vasculature. This is due to poor or absent blood flow to target tissues, which quickly become ischemic and present with pain symptoms, typically described by the examinee as a throbbing or a diffuse pain. So throbbing is one indication that you're dealing with a vascular type source of pain. Many examinees will describe headache pain by using terms such as throbbing or pulsating type of pain, and this is a dead giveaway that you're dealing with a vascular originated type of pain. Now, typically also we're going to be dealing with examinees whose pain is of neuromusculoskeletal origin, and this is to be differentiated from pain of systemic origin, and both systemic and musculoskeletal pains have distinct and unique characteristics. So typically with the examinees that we're going to encounter in the workers' compensation system with injuries to the spine, to the upper and lower extremities, this is going to be generally pain that's present and aggravated by mechanical stress and generally relieved and alleviated by cessation of activity. So this is pain that typically lessens at night as activity ceases, whereas systemic pain is pain that continues throughout the night and is independent of the level of activity. With musculoskeletal pain, the pain is typically described as a sharp or a superficial pain, and the examinee is able to very well localize the location and the source of the pain. Whereas systemic pain, because it's coming from deeper structures, is described as deeper pain. It's described as an aching pain, as a throbbing pain, as a boring type of pain. And this reflects the specificity with which the sensory receptors are able to localize the pain. Again, musculoskeletal pain usually decreases with cessation of activity, whereas systemic pain is characterized by constant waves of pain and spasm that are unrelated to activity. So that's a key giveaway, and that's a key question that you might employ in your history taking, and that is by asking the examinee what types of activities increase the intensity of the pain and what activities cause a decrease in the intensity of the pain. And with systemic pain, you'll find that the pain is unrelated and is unaffected by the level of activity. And let me just give you an example of that. I'm reminded of an occasion wherein about a couple years ago, I had an episode of food poisoning. I had stopped by a roadside stand for a tamale, and very quickly after eating the tamale, I learned that there was something rotten in that tamale, and my guts quickly rebelled on me with diarrhea and vomiting and spasm and constant waves of spasm in the digestive organs. And even when I went to bed at night, as I lay there in my misery, the pain continued and was not relieved by cessation of activity. And this pain kept me up all night until common sense got the better of me, and I called for an emergency transport to the emergency department for medical treatment of this pain. So systemic pain is greatly different from the typical musculoskeletal pains that we encounter in the qualified medical evaluation. And so when you have examinees who present to you and tell you that their pain disturbs their sleep, that the pain is deep and throbbing and poorly localized, that the pain involves constant waves of pain and constant spasm, these are red flags that indicate to you that some further investigation is necessary, and perhaps the examinee has some other things going on in addition or in place of the neuromusculoskeletal injury that they're alleging. So some of these systemic pains can be related to generalized conditions such as migratory arthralgias, such as jaundice, such as weight loss, such as low-grade fever, such as tumors, and also such as infections. So these types of pain descriptions would be red flags that would require additional investigation and maybe even unrelated to the industrial injury as alleged. So in addition to those neuromusculoskeletal and systemic causes of pain, we know that if we go back to our definition of pain from Merriam-Webster, Merriam-Webster told us that pain is an unpleasant sensory and emotional experience. So we know by that definition that the emotions can strongly impact the perception of pain. So stress is something that we need to assess in our examinee. And we know that stressful life circumstances such as divorce, such as marital problems, such as financial problems, such as job stress, such as a relocation, such as problems with the children, can increase the perceptions of our examinee's stress. And this is something our examinee's perception of pain. And this is something that we need to consider as qualified medical evaluators in assessing the true impact of pain on our examinee's condition and in assessing our examinee's true limitations with activities of the daily living. And that is, how is stress, non-industrial stress, impacting our examinee? So some of the common reactions to stress that we're going to see in our examinee is an increased description of aches and pains throughout the body. Examinees under stress will demonstrate anxiety. They will report recent changes in their appetite, both increased and decreased appetite. Maybe they'll report to you weight gain or weight loss. And this is an example and a dead giveaway that the examinee, in addition to the industrial injury, has some form of non-industrial stress that needs to be considered in your overall assessment. Examinees in stressful life circumstances will report difficulty concentrating, difficulty sleeping, irritability and impatience, anhedonia, which is known as loss of interest and loss of enjoyment in life. They may even present to you in the face-to-face evaluation with trembling or sweaty hands, and they may generally appear to be withdrawn. So these are non-industrial contributors to the alleged industrial injury, which is the cause of the examinee's pain. So in assessing the examinee's pain and assessing the examinee's performance on physical examination, the qualified medical evaluator needs to be cognizant of the fact that non-industrial stress can enhance and augment the examinee's response to physical examination and other pain stressors. Now, along those same lines, because we know that pain is an emotional experience in addition to a sensory experience, in examinees who have bona fide chronic pain, don't be surprised to find examinees laden with emotional side effects from that pain. Some of these emotional overlays of pain we're going to be able to discover in our activities of daily living assessment. And some of these other aspects of the emotional component of pain, we can just simply pick up by the observation of the examinee or through our interviewing techniques in the face-to-face interview. So commonly, examinees in chronic pain sufferers will present with emotional problems including chronic anxiety. This is something that we may observe in the face-to-face evaluation. They may present with anger or irritability in the face-to-face evaluation, where they become short and quick-tempered with you for no apparent reason. They may have decreased self-esteem, and this can present with the way they dress themselves and the way they groom themselves, and even in the way they present themselves to you with their body language. They may have financial and legal issues that you're able to discern either in the interview, or sometimes you'll get some indication of this in your review of records. I'm reminded of a case that I recently had that involved an injured worker alleging industrial injury, and the allegation of industrial injury came 2 weeks after he received notice that his wages were going to be garnished for overdue and delinquent child support payments. So this is a person who had both legal and financial issues simultaneously. Examinees with chronic pain will become depressed, and their physical condition will deteriorate. This will manifest in the form of weight gain, weight loss, aversion, or disinterest in exercise. In our activities of daily living assessment, when we assess sexual activities, examinees with chronic pain will tell you that they have a reduced sexual interest and a reduced frequency of sexual activity. I find this to be equally common in both men and women, who explain to me that they just don't have the interest in the sexual activity that they had. Most commonly, this is due to pain, and because of pain and the cumbersome impact of pain upon sexual activities and upon their partner, it's just easier to reduce the frequency of sexual activity. Also, examinees in the face-to-face interview, when you discuss their sleeping habits and the impact of their condition upon their sleep, they'll tell you that they have sleep disturbances. They'll report daytime sleepiness. They'll report all types of changes in their schedule, such as staying up late at night because they're not tired, and sleeping in late during the morning because they're too tired, and taking naps throughout the day, and all different variations of disturbances in their sleep. And they may also express to you contextual or system-based issues, including problems at work, job dissatisfaction, and difficulties with their immediate supervisor. So pay particular attention to the emotional aspects and the emotional impact of pain on the examinee's life, because these emotional factors and these emotional indicators can serve as true objective findings to substantiate an opinion or an assessment for a chronic pain condition. So this is an example where these observations that you as a qualified medical evaluator make in the face-to-face interview, in the activities of daily living interview, and in the physical examination, these findings, these emotional findings, serve as true positive objective examination findings, which would substantiate the examinee's allegation of a chronic pain condition. Now, another area where we're going to encounter examinee pain has to do with repetitive stress and cumulative trauma. And with the increase in cumulative trauma claims that are being filed recently in the California workers' compensation system, it's important to understand the progression of the development of pain in repetitive stress and cumulative trauma types of injuries. So pain in cumulative trauma injuries begins with first pain after a specific activity. Now, you might be familiar with this phenomenon. And that is you go out to do some sort of a specific activity, and I'm going to relate this to you as doctors. Maybe you go out to do some workouts, maybe some running workouts or some weight training workouts, or maybe you go down to your garage to do some moving of boxes down in the garage, and you go through this specific singular activity. So if we're talking about running, we're talking about running. If we're talking about working out at the gym and doing resistance exercise, maybe we're talking about the specific activity of bench press or the specific activity of doing squats. Or if we're talking about working in your storage shop, we're talking about the specific activity of moving boxes, which involves bending and lifting. Okay, so these are the specific activities. So you go to do these activities, and the activity is unaffected. You're able to fully perform the activity without pain and without limitation. But you notice that later, after that specific activity, such as running 2 miles, such as doing the bench press, such as moving boxes in your garage, that you have some pain. Well, with time and with cessation of the activity, of that specific activity, meaning perhaps you go on to other activities, you go on to other running protocols or other workout body part regimens or other chores down at your shop, that pain resolves. Okay, so that's level 1 of repetitive stress pain. Well, if there's not adequate recovery between the time of performance of that specific activity and you coming back to now repeating that specific activity, if there's not been adequate recovery, then some component of that pain, some component of that micro trauma is still going to persist. And this is going to manifest as pain at the start of the activity that resolves with warm-up. And I know you're familiar with this phenomenon. Let's say you're going to the gym and you're planning on doing some bicep curls. And you start doing your bicep curls and you notice that there's some pain and some tightness and some weakness in your bicep tendon down at the elbow. And you remember that just 2 days ago you did some heavy activity or heavy workout of pulling or rowing that also incorporated that bicep tendon, and that bicep tendon is not yet fully recovered by the time that you begin now another specific activity that loads or stresses the same tissue involving the bicep tendon. Well, as you go through your warm-up procedure, you notice that while it's initially painful and initially weak and stiff, that those symptoms quickly resolve and you're able to get in to the meat and the matter of your workout, and you're able to successfully complete a satisfying workout without additional injury or pain. Well, as the cycle of repetitive and cumulative stress accumulates, and as that cycle starts to intensify, you notice that you then develop pain during and after the specific activity. In other words, it's now becoming to the point where the pain does not resolve after warm-up, and the pain continues during the activity, and it also manifests itself after the activity. But despite the presence of pain, bona fide pain, the pain does not seem to interfere with your ability to perform the activity, and it doesn't interfere with your ability to perform well during the activity. In other words, you can successfully complete at a high level the activity in question. So let's say you go to the gym and you're going to do some squats today. Well, as you start to warm up your squats, you notice that your knees are a little stiff and achy and painful, and the session of squatting is less than pleasant, if you know what I mean. It's not pleasant, it's not fun, it's not enjoyable, but you're able to get through it, you're able to accomplish your objective, and you're able to perform well, but there's pain. But the pain is not such that it causes any impact on your ability to successfully complete a satisfying session of squats? Well, as this repetitive stress cycle continues, you notice that the pain worsens, and now the pain gets to the point where the pain starts to impact your ability to successfully perform the activity. So this is level number 4, which involves pain during and after the specific activity that now starts to affect performance. Typically, the pain affects performance by causing weakness through pain inhibition. So using our example of working out at the gym, or even using our example of lifting boxes down at the shop, you'll notice that you're able to do your squats at the lighter weights, but as you pyramid up the weights, now the pain and pain inhibition becomes prohibitive, and you find that at least today, on this particular day, the pain is preventing you from getting up into the higher levels of performance, and it's preventing you from doing the higher weights that you may have planned on being able to do that day. Or if you're down at the shop moving boxes, you may find that you're able to move small boxes, but because of the pain and the resulting pain inhibition weakness, you're not able to lift the heavier boxes that you had planned to be able to lift. So this is an example of pain inhibition, where the pain starts to impact the successful and high-level performance of the specific activity. And again, we're here referring to not all activities, but we're referring to the specific activities that cause the pain. Well, as the cycle of repetitive and cumulative stress continues, we find that the pain starts to spill over into other activities as well. So whereas before you were experiencing pain only with the specific activity that caused the pain, as the cycle worsens and the micro trauma and tissue damage worsens, the pain starts to affect all or other activities of daily living. Other activities of daily living that employ the same mechanical actions or the same neuromusculoskeletal body regions. Well, pain level 6 becomes a constant dull aching pain at rest that does not disturb sleep. But the pain is present not only during activity, in other words, you have pain not only during and after activity, but now the pain progresses to the point where you have pain even at rest with cessation of activity. Now, it's at this point that there's a dividing line between number 5 and number 6 here. This is where the AMA guides begin to provide for permanent impairment as the pain starts to impact activities of daily living. So finally we get to level 7, where the pain is a dull aching pain that now, whereas before it did not disturb sleep, now the pain is so constant and so deeply embedded that it impacts and interferes with your ability to get a normal night's sleep. So this is a progression that you can expect in your examinees who are reporting cumulative trauma or repetitive stress type of injuries. Now notice that with pain levels 1 through 5, really the pain has no impact on the activity, or if it does affect the activity, it affects only the specific activity that's the cause of the pain. Other activities are relatively spared. So the dividing line for the AMA guides would seem to be between numbers 3 and 4, where we start to get some specific limitation with the activity that causes the pain, and then certainly below pain level of 5 as the pain starts to spill over and impact and limit other activities of daily living. Then we can expect some permanent impairment to result from these levels of pain. But before that, levels 1, 2, 3, and even possibly 4, if it's an activity of daily living that's relatively benign, the AMA guides may provide for 0% impairment due to no impact on activities of daily living. So it's important for you to make an assessment as to how the examinee's pain impacts, if at all, their performance of specific activities and then also general activities of daily living. Okay? Now, this concept of pain and the impact of pain on activity is not new to us. If you have been doing qualified medical evaluations for any length of time, you remember that before 2005 and before the incorporation of the AMA guides, we used to use earlier disability rating schedules that employed what we referred to at the time as words of art. And one of the factors of disability for which the examinee could be awarded permanent disability had to do with what were referred to as the subjective factors of disability. Well, the subjective factors of disability was a way that we could provide an idea to the reader of our report as to how the examinee's subjective report of pain impacted their ability, if at all, how it impacted their ability to perform activities. So we had 4 different types of pain. We had minimal pain, we had slight pain, we had moderate pain, we had severe pain. And you may even refer to these different types of pain if you have a pre-2005 case wherein the former 1997 permanent disability rating schedule is the appropriate and applicable schedule. You may use these words of art. So these words of art apply both to the 1997 permanent disability rating schedule, and also, in my opinion, they apply to our current rating schedule under the AMA guides, because these descriptions of pain are illustrative and lend great insight into the examinee's pain and lend insight as to how the examinee's subjective description of pain impacts their ability to perform activities. Now, let's put this in context, because all examinees will describe their pain as severe. Examinees will tell you that their pain is an 8 or a 9 or a 10 on a 10-point pain scale. And examinees have a tendency to overrate their description of pain. So this, using these terms of art, this is one way that we as examiners can use to truly get a sense as to how bad the examinee's pain is. So for example, with a minimal pain is a nuisance pain. It's pain that's there, but this pain does not interfere with the performance of the activity that causes pain. So an example of this would be a basketball player. Say, for example, a basketball player comes off the court at halftime and tells the coach that his knees are killing him. And then in the second half of the game, this same basketball player goes out on the court, runs up and down the court, and scores 25 points and grabs 10 rebounds. What does that tell you? The ability to score 25 points and the ability to grab 10 rebounds, what does that tell you about the examinee's level of pain? Well, does it tell you that the examinee has pain? See, we don't know if the examinee actually has pain or if the basketball player has pain. He says he has pain. The only thing we can discern is that the pain that he has does not interfere with his ability to play basketball at a very high level, to the extent that he's able to score 25 points and grab 10 rebounds. So this is what we refer to as a minimal pain. It's a pain that's there, according to the examinee or the basketball player. The pain is there, but we can determine that the pain is not too bad because the pain doesn't interfere with the activity that causes the pain. And you may have many of these minimal pains in your own body, as well. They're there, they're nuisance pains, but fortunately they don't interfere with the performance of activities. The next level of pain, according to the 1997 PDRS, is a slight pain. Now with a slight pain, we get some handicap in the performance of the activity that causes the pain. So in this case, with the example of a basketball player, we might notice that the basketball player has some handicap in his ability to run up and down the court. Maybe he doesn't run the full length of the court. He shortens the court to shorten his running distance. Maybe he has a limp, a slight limp, as he runs down the court. Even though he's able to still run down the court, he has some limp that affects his ability to run. Maybe he's not able to jump or not jump as high in getting some rebounds as he would be able to do without the pain. But in other words, the pain now starts to encroach upon or impact the activity that causes the pain. Typically, the impact on the pain affects range of motion and also affects strength. So these are two areas in your physical exam where pain, bona fide pain, would limit the examinee's performance on physical examination maneuvers. They would have a reduced range of motion or a reduced strength throughout the range of motion. The next level of pain is a moderate pain, and now pain is starting to get to be a problem, because with moderate pain we have a marked handicap in the performance of the activity, and it becomes increasingly difficult to perform at a high level in the presence of moderate pain. I'm reminded recently of a tennis match I was watching recently here a couple weeks ago, where Andy Murray, the British tennis player, was trying to make a comeback after a recent hip surgery. And he was out on the court, and for all intents and purposes he was playing very, very well. But to the trained eye, and even to the not so well trained eye, I say that because I know that my wife, she also observed this phenomenon, that Andy Murray did not have his usual speed in running. He didn't have his running speed. He was not able to stop and start quickly and forcibly. He was not able to pivot quickly and definitively. And his whole performance seemed to be handicapped by restriction in range of motion. I noticed it to be restriction in hip extension. And so here, even though he was playing professional tennis at a high level, in other words, he was being competitive in this match, which he ultimately did lose, but he was able to be competitive even in the presence of a limp, and even in the presence of reduced court speed and reduced court agility. But there was a definite handicap in his performance. So this is an example of a moderate pain. And then most examinees will describe a severe pain even though they don't have severe pain, because severe pain is very easy to identify. Severe pain is pain that precludes the activity. So I don't know if you've ever had severe pain. Maybe you want to bend over and pick something up, and on your way down to pick something up off the floor, you get a sharp pain in your back that gets your attention and stops all activity, and that's an example of a severe pain. Now, the 2001 Physician's Guide describes severe pain as pain that precludes all activity. So with severe pain, these are examinees that you would expect to see on a gurney in the emergency room with all activity precluded. So many examinees will tell you that they have severe pain, when in actuality the pain that they're actually having is more accurately described as a minimal or a slight pain. And you want to ask yourself, what's truly objective here? The examinee's descriptions of pain, however they describe that pain to you, is subjective. Your job is to find out what's truly objective here, and to translate for the reader of your report your examinee's subjectivity into a true and accurate description of their condition. So your job is to translate the subjectivity into something more objective, such as a description of minimal pain, slight pain, moderate pain, severe pain, by observing how does this pain interfere with the examinee's activity. And most examinees have little or no limitations in activity. They drive themselves to the appointment. They walk unassisted, without an assistive device. They perform well on physical examination maneuvers. So most examinees' pain will fall into the minimal and the slight pain categories. Now, if that's true, if most examinees have what can best be described as slight or minimal or slight pain, that tells you that the examinee's pain, regardless of how bad it is, regardless of how they describe it to be, that pain very little or has very little impact on their activity. Well, according to the AMA guides, if the pain has no limitations to activities of daily living, this qualifies for 0% whole person impairment rating. According to the AMA guides, examinees do not qualify for permanent impairment unless and until their pain impacts their activities of daily living. So in other words, the AMA guides do not provide for permanent impairment for minimal and even possibly even slight pains. The AMA guides tell us, I think it's on page 5, that a 0% whole person impairment rating is assigned to an individual with an impairment. They have a bona fide impairment, but even in the presence of a bona fide impairment, if the impairment has no significant organ or body system functional consequence and does not limit the performance of the common activities of daily living indicated in table 1.2, this qualifies for a 0% whole person impairment rating. And if you're familiar with the old rating schedule, the 1997 permanent disability rating schedule, this description from the AMA guides is consistent with the 1997 permanent disability rating schedule, where there was no disability rating for minimal pain. In other words, then and now, there is no impairment or disability rating for pain if that pain does not rise to the level that it interferes and impacts activities of daily living. So one of the key things that you want to always be attuned to with your examinee is, how does the pain impact their activity? How does the pain that they describe to you through the course of physical examination maneuvers impact their ability to perform the physical examination maneuver? If the examinee tells you that during a physical examination maneuver, oh, there's pain, 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 oh, pain, 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 and they're fully able to complete the physical examination maneuver without evidence of evasive action, without evidence of a flex or withdrawal response away from the pain, that tells you that regardless of how much pain they're having during that physical examination maneuver, there is no true positive objective finding that the pain is interfering with their ability to complete the physical examination maneuver. Isn't that a fascinating concept that brings together all of these varied philosophies about pain? See, pain that does not impact activity, pain that does not involve an evasive action, pain that does not involve some component of the flexor withdrawal reflex is simply a subjective description of pain. And for subjective descriptions of pain without impact on activities of daily living, without impact on the ability to perform the physical examination maneuver that causes the pain, there is no true positive objective finding. And the AMA guides tell us that in the absence of true positive objective findings for impact of pain on activity, there is a 0% whole person impairment rating, because the pain does not impact the activity. Isn't that fascinating? Okay, so that concludes our session on pain concepts for the qualified medical evaluator. In our next session, we're going to go into the true positive objective findings and true evasive actions and true examples of the flexor withdrawal response, in relation to our physical examination of the cervical spine, the lumbar spine, the upper extremity, and also the lower extremity. So I look forward to being with you on our very next session.